Hemorrhoids. Donna I. Meltzer, MD. Basics. Description: varicosities of the hemorrhoidal venous plexus. External hemorrhoids located below the dentate line. Visceral innervation, painful, covered by squamous epithelium. Internal hemorrhoids located above the dentate line. Somatic innervation, painless, covered by columnar epithelium. Classification of internal hemorrhoids. 1. Grade I. Hemorrhoid vessel bulges without prolapse. Grade 2. Hemorrhoid prolapses with straining but reduces spontaneously. Grade 3. Hemorrhoid prolapses with straining and requires manual reduction. Grade 4. Chronically prolapsed, can't be reduced. Internal and external hemorrhoids often coexist. Although often asymptomatic, hemorrhoids can present with itching, bleeding, soilage, prolapse, or pain. Pain and thrombosis more common with external than internal hemorrhoids. Geriatric considerations: hemorrhoids and rectal prolapse are more common in elderly. Pediatric considerations: uncommon in infants and children. Most common cause is chronic liver failure. Other findings: rectal polyps, skin tags, condyloma, often misdiagnosed as hemorrhoids in adolescents. Chronic constipation and prolonged toilet time can result in hemorrhoids. Pregnancy considerations: common in pregnancy, usually resolves after delivery. No treatment required, unless extremely painful. Epidemiology: predominant age, adults, peak from 45 to 65 years. 2. Predominant sex, male equals female. Incidence: common, over 3.5 million office visits per year are related to hemorrhoidal disease. Prevalence: 4–5% in general population in the United States, 39% prevalence on routine screening colonoscopy. 2. Etiology and pathophysiology: exact pathophysiology is unknown. There are 3 primary hemorrhoidal cushions typically located in left lateral, right anterior, and right posterior positions. Hemorrhoidal cushions augment anal closing pressure and protect the anal sphincter during stool passage. During Valsalva, increased intra-abdominal pressure raises pressure within the hemorrhoidal cushions. Mechanisms implicated in symptomatic hemorrhoidal disease include dilated veins of hemorrhoidal plexus, tight internal anal sphincter, abnormal distension of the arteriovenous anastomosis, prolapse of the cushions and the surrounding connective tissues. Genetics: no known genetic pattern. Risk factors: pregnancy, pelvic space occupying lesions, liver disease, portal hypertension, HTN, constipation. Occupations that require prolonged sitting, loss of perianal muscle tone due to old age, rectal surgery, birth trauma/episiotomy, anal intercourse. Obesity, chronic diarrhea. General prevention: avoid constipation by consuming high-fiber diet, greater than 30 g/day, and ensuring proper hydration. Maintain appropriate weight. Avoid prolonged sitting or straining on the toilet. Commonly associated conditions: liver disease, cirrhosis, ascites. Pregnancy, constipation. Diagnosis: diagnosis is typically straightforward through history and inspection of the perineum, rectal exam, and anoscopy. History: symptoms: 1. Bleeding, 60%, classically, bright red blood per rectum, may range from scant blood on toilet paper to copious blood in the toilet bowl. Pruritus, 55%. Perianal discomfort, 20%, soiling, 10%, constipation or diarrhea. Straining with defecation. External hemorrhoids: episodic bleeding on stool or toilet paper, pruritus, and irritation from compromised hygiene and pain. More extensive internal hemorrhoids: feeling of incomplete evacuation. Thrombosed hemorrhoids present as acute painful mass. Ask about diet, fiber, fluid intake, bowel patterns, frequency, consistency, bowel habits, prolonged sitting, change in stools, systemic symptoms, weight loss, pain, fever. Ask about past medical history and family history, gastrointestinal disease, colorectal cancer. Physical exam: visual anorectal inspection with Valsalva maneuver. Digital exam with anoscopy. Internal hemorrhoid appears as purple mass on lumen wall. Examine for additional anorectal pathology, mass, abscess, fissure, fistula. Attempt to reduce prolapsed hemorrhoids. Abdominal exam to exclude mass. Peripheral stigmata of cirrhosis and portal HTN, caput, telangiectasias, palmar erythema, Differential diagnosis: rectal or anal neoplasia, condyloma, skin tag, inflammatory bowel disease, anal fistula, fissure, or abscess, rectal polyp, rectal prolapse. Diagnostic tests and interpretation: initial tests, lab, imaging, not indicated unless anemia is suspected. Diagnostic procedures / other sigmoidoscopy or colonoscopy depending on risk factors for malignancy in patients with rectal bleeding. Treatment: prevention, fiber supplements, stool softeners, anal hygiene. General measures: hemorrhoids are a recurrent disease, even after surgical excision. Preventive measures should be continued indefinitely. For mild symptoms or prevention, avoid prolonged sitting during bowel movements. Avoid straining. Avoid constipation by eating a high-fiber diet or by taking fiber supplements. If necessary, take regular stool softeners. Regular exercise. Weight loss if indicated. Pruritus or mild discomfort after stooling might respond to topical corticosteroid ointment, anesthetic ointments, or sprays, and warm sitz baths. Constipation relief: anal hygiene, local ointments, and sitz baths are effective through the stage of easy reduction, grade 2. More severe stages often require ligation or surgery. Medication: first-line dietary modification with adequate fluid, generally greater than or equal to 2 L water per day, and high fiber, 25 to 35 g/day, is first-line, non-operative therapy for symptomatic hemorrhoids. 1. Fiber helps relieve overall symptoms and bleeding. 3. A. Stool softener or bulk-forming laxative to soften stool: sitz bath with warm water for pain relief. Witch hazel, tux, as a wipe after stooling may be useful for astringent properties. Topic: anesthetics: benzocaine, lidocaine, pramoxine, steroids, emollients to alleviate symptoms. These over-the-counter, OTC, products have been traditionally used but lack strong evidence for long-term use. Local anesthetics for relief of pain and itch, applied to perianal area, not inserted into rectum. Dibucaine 1% ointment, nupercanol, lidocaine 5%, preparation H, tux, pramoxine 1% foam, ointment, wipe, proctofoam, benzocaine 20% spray, ointment. Use sprays with caution as alcohol in product may cause burning sensation. Anti-inflammatory agents, corticosteroids, to decrease swelling and for discomfort and itch. Hydrocortisone ointment, cream, 0.25 2.5%. Anusol HC, cortifoam. Rectal suppositories are for short-term use only. Astringents to help dry skin: witch hazel solution, wipes, pads, preparation H, tux, vasoconstrictors to shrink hemorrhoids and ameliorate bleeding, pain, itch 0.25%. Phenylephrine ointment, suppository, gel, preparation H, recticaine, second-line treatment for special cases: thrombosed external hemorrhoids. If present within 72 hours after pain onset, recommend incision and clot evacuation or excision of hemorrhoid complex. Early surgical excision may resolve symptoms faster and lower incidence of recurrence. 3. C. Strangulated hemorrhoid. Untreated irreducible hemorrhoid can progress to ulceration and thrombosis. Treatment requires urgent or emergent hemorrhoidectomy. 4. A. Acute hemorrhoidal bleeding associated with portal HTN can be life-threatening. Treatment should involve medical management and correction of coagulopathy, sclerotherapy, suture, ligation, and surgical shunts, if necessary, surgery / other procedures. Indications: failure of medical and non-operative therapy, symptomatic grade 3 or 4 hemorrhoids in presence of a concomitant anorectal condition requiring surgery, or patient preference. Office-based procedures for patients with grade I or 2, or 3, internal hemorrhoids who have failed conservative management. Rubber band ligation, RBL, most common and most effective office-based procedure for symptomatic internal hemorrhoids. Avoid if on anticoagulants. 3. A, 5. Infrared photocoagulation. Infrared light waves cause necrosis within hemorrhoid. Similar or slightly higher recurrence rates compared to RBL, less postoperative pain and fewer complications. 1, 2. A, 3. B. Sclerotherapy. Submucosal injections causing local thrombosis might be best for patients at increased bleeding risk. Anticoagulated, advanced liver disease, care must be taken to inject proper site, not for advanced disease or if evidence of infection, inflammation, and ulceration is present. Cryotherapy is no longer recommended due to high rate of complications. Surgery for patients with symptomatic grade 3 or 4 disease who have failed non-operative treatments. 3. A conventional hemorrhoidectomy. Closed hemorrhoidectomy. Closure of mucosal defect. Open hemorrhoidectomy. Tissue removed and mucosal defect left open. Different technologies are now used to excise hemorrhoidal tissue: diathermy, lasers, ultrasonic dissectors, associated with less pain. Newer techniques reduce surgical time, early postoperative pain, urinary retention, and time to return to normal activity. Doppler-guided/assisted hemorrhoidal artery ligation, HAL anoscope or proctoscope with Doppler probe identifies hemorrhoidal artery, which is then ligated, favorable in terms of outcome and postoperative pain in advanced hemorrhoidal disease. 6. B. Stapled hemorrhoidopexy for advanced internal hemorrhoidal disease. Excises submucosa, shorter recovery but more recurrent disease than conventional hemorrhoidectomy. 2,5. A, 6. B. Ligature hemorrhoidectomy, reduces operating time, is superior in terms of patient tolerance, and is equal to conventional hemorrhoidectomy in long-term symptom control. 2. A. Complementary and alternative medicine. Oral bioflavonoids have shown beneficial effect on bleeding, pruritus, and recurrence. 3. A. Topical nifedipine, compounded by pharmacist, can relieve pain of thrombosed hemorrhoids. Topical nitroglycerin, 0.4%, has been used to decrease anal sphincter spasm in thrombosed hemorrhoids. Headache is primary side effect. Botulinum toxin injection into anal sphincter to relieve spasm and pain of thrombosed hemorrhoid. Aloe vera cream on the surgical site after hemorrhoidectomy reduces postoperative pain and decreases healing time and analgesic requirements. Ongoing care follow-up recommendations encourage physical fitness, weight management, and dietary compliance. Avoid prolonged sitting and straining on the toilet. Patient monitoring is needed, depending on treatment. Diet high fiber with a target of 30 grams of insoluble fiber per day through sources such as wheat bran cereals, oatmeal, peanuts, artichokes, beans, corn, peas, spinach, potatoes, apples, apricots, blackberries, raspberries, prunes, pears, bananas. Adequate fluids, 6 to 8 glasses of water per day. Avoid excessive caffeine. Patient education. Top fiber-rich foods list. http://www.todaysdietitian.com/new archives/0630008p28.html. Prognosis: spontaneous resolution, recurrence, complications, thrombosis, ulceration, anemia.